This week on the BackTable podcast.
So 96% from stage 2 through stage 4. I'm sure there is variation. The worse staging you have, then the less you can expect that result. But yeah, it seems like it's by far the best treatment for ORN of the mandible that's ever been developed by human beings.
There was a well-designed study out of MD Anderson looking at segmental mandibulectomy and reconstruction for mandibular ORN. And again, this is maybe at an earlier time point where, the ALT rescue flap wasn't really widespread. And so maybe there was a larger range of patients who had failed conservative therapy and therefore underwent a segmental mandibulectomy and reconstruction, who might otherwise now in retrospect have been a candidate.
My name is Ashley Agan, and I will be your host today. And I am joined by two of my best and brightest friends and free flap surgeons, Dr. Ariel Frost and Dr. Eli Gordin. You may remember Eli from episode 128. We talked about kind of like free flaps 101. So go back and check that out if you missed it. And today we're going to talk about osteoradionecrosis of the mandible. Welcome to the show, you guys.
Thank you.
Thank you.
So before we get into it, we like to just start the show by asking you to tell us a little bit about yourself and your background. Ariel, do you want to go first?
Sure. I'm Ariel Frost. I grew up in California and did all of my childhood there before transplanting to the Northeast for the majority of my education and training, except for my final year of training in the Midwest at Cleveland Clinic. And I have been in practice at UT Southwestern as a facial plastic and microvascular surgeon, just finishing up my second year now.
And my name is Eli Gordin. I'm an associate professor at UT Southwestern in the section for facial plastic and microvascular reconstructive surgery. I've been at UT for, I think, 8 years now, 7 or 8 years, and in practice for about 11 years. Did most of my training on the Northeast in Philadelphia, which is where I was born and raised. And yeah, go Birds, I guess,
So you guys, both of your practices have a heavy amount of recon. You do a lot of free flaps. And I think, in the last couple of months, this came up because you guys were talking about free flap surgery as it relates to the management of mandibular osteoradionecrosis or ORN. And for me, as someone who's been out almost 10 years now and doesn't really take care of a lot of head and neck cancer patients or post-radiation patients, there was a lot of new information that has changed since I was in residency. And so I said, hey, you got to come on the show so we can talk about it. So thank you both for taking the time today. I think this is going to be a really interesting conversation. And so before we dive into it, just, setting the stage, kind of talk about just overall background of what is ORN, what is it? How do these patients present? What is it? What are we talking about here?
Yeah, I can start with this. So kind of overall, you really also have to step back and understand the role of radiation therapy for head and neck cancer. So radiation for head and neck cancer has significantly increased over the last few decades, and that's really improved recurrence and survival rates. There are a lot of new technologies such as IMRT, which is intensity modulated radiation therapy, but there are still a lot of treatment-related toxicities, and the most persistent and serious one is osteoradionecrosis, or ORN of the mandible. We define mandibular ORN as 3 months of a non-healing irradiated bony exposure of the mandible without evidence of neoplasia, so no evidence of cancer. And the incidence ranges from 4 to 8%, sort of in this modern era of radiation. And finally, the mandible is sort of the main site in the head and neck that we see ORN, although other subsites are involved as well. But the mandible is particularly vulnerable due to, its proximity to the oral cavity and oropharyngeal tumors in sort of this dense bone structure that has a relatively isolated blood supply, which makes it particularly susceptible to sort of vascular changes with radiation, which then creates these these non-healing wounds and issues with bone viability.
Yeah, I think as Ariel mentioned, radiation is quintessential to treatment of head and neck cancer, and she touched on oropharyngeal radiation a little bit beyond the scope of this, but oropharyngeal cancer has been rising over the last couple decades with HPV-mediated squamous cell carcinoma, and generally that's a non-surgical treatment, although towards the side it's a little bit controversial. We are not experts in cancer, but there's a large subset of patients that get only radiation treatment for their oropharyngeal cancer, to a lesser extent oral cavity cancer. And for the people who are not familiar with the way the radiation treatment works, essentially they're drawing like a dose curve, meaning they want to deliver a certain amount of dose, which is measured in gray, to a target area, i.e. the tumor. And then the machine, which is essentially like an X-ray machine, it shoots a collimated beam of radiation, meaning like a narrowly focused beam of radiation from a specific direction, and then they can rotate the machine and target the tumor from multiple angles. So if you're able to distribute the radiation across a wider area of tissue, then you're not going to damage kind of the tissue through which the radiation is passing to get to the target area as much, but inevitably the tissue that's in between the target and the radiation machine is going to get some degree of dose. And so therefore the mandible is in the way when you're targeting the oral cavity and the oropharynx, and you end up with the mandible getting damaged to some degree. Most people's mandibles can regenerate, but a certain subset will go on to develop osteonecrosis.
And so we're talking about patients who have head and neck cancer, specifically like oral cavity or oropharynx. And as far as like risk factors for patients who are most likely to have a complication of ORN, I remember, in residency, we always had to make sure patients saw dental before they saw radonc. So, carious dentition is a risk factor, right? And what other things might put patients at risk for developing ORN after their treatment?
Yeah, it's super important for patients to have a dental evaluation prior to starting radiation treatment. Poor oral hygiene is a risk factor. Any unaddressed dental issues, like you mentioned, dental caries or gum disease, inevitably they're getting some degree of xerostomia or dry mouth from the radiation. Saliva is protective for the dentition. So if you have an entry point for infection, if you have any source of trauma like surgical, so dental extractions after they've had their radiation, especially within the first year, or dental implants, again, risk is higher within the first year, but patients have to be extremely careful if they're going to have any kind of dental procedure after they've had radiation, whether it's 1 year afterwards or whether it's 10 years afterwards. Very important for patients to see either a dentist or oral surgeon who is well-versed in treating patients who have had radiation treatment that affected the mandible, because you can't just go extracting teeth without being very careful, essentially. And so it's not something that if you had radiation treatment to the mandible for your patient or for you, like a community dentist who doesn't have experience with that is not necessarily the person to see. And then other things are like smoking, diabetes, wound healing, things that make you less susceptible to having a successful healing wound are going to give you a higher rate as well.
Yeah, that makes sense. And so typically just kind of thinking about how these patients are walking into clinic, they've had a history of radiation treatment for their head and neck cancer, and what kinds of, what are they experiencing and what are you seeing on exam?
Yeah, patients will typically have a history of maybe a recent dental procedure, which caused an inflammatory environment. And as Eli mentioned, perhaps in a non-irradiated individual, this would be an innocuous occurrence and it would heal. But instead, they'll describe a history of a non-healing wound. It typically kind of rises and falls in these sort of infectious and inflammatory phases. So they have episodic pain, drainage, ulceration with bony exposure. On the more severe side of things, the entire mandible can be involved, meaning the full sort of vertical height of the mandible, and that compromises its structural integrity. So patients on the more advanced side of things may be presenting with a pathologic fracture. Also, on the more advanced side of things, patients may present with an area of drainage, which to them they'll describe as a, area that dries up and drains and is sort of bothersome, painful, maybe malodorous, sort of infectious type symptoms. But that really represents a fistula, sort of full thickness process, like a orocutaneous fistula or a pharyngocutaneous fistula.
How far out from radiation treatment are patients typically presenting? Like, is this something that happens pretty soon after they're finished with their treatment, or are they showing up a year later, or it can vary? Is there anything that's typical?
Can be at any point. Like I was alluding to earlier, even years, sometimes we see patients who had radiation treatment in almost 20 years ago who develop it, because a lot of times it requires some sort of inciting event, whether it's bad dental infection, whether it's a dental extraction, or, people fall or have traumatic incidents where they might have trauma to the mandible, not necessarily a broken mandible, but that too, if somebody somehow manages to have a fall and break their mandible after they've had a history of radiation, that's going to be a lot more difficult to get that patient to heal. But if they have a procedure, like I mentioned, within the first year after radiation, then that's going to put them at higher risk. But there's still a risk ongoing with any complication of radiation. Tends to be kind of a long-term evolving process.
Is there always that kind of inciting event? Does it ever just kind of like gradually happen, or is it usually after like a dental procedure, like you mentioned?
It can be spontaneous, but a lot of times you don't really know. Sometimes patients come in, they have a classic kind of story where they had some dental extraction and then that kind of set off a whole chain of things, but sometimes it's not clear.
Got it. And on exam, you're seeing just like you mentioned like maybe some exposed bone. Does it bleed? Is there pus?
Yeah, in the intraoral exam, depending on the, location of the ORN, there may be some trismus that also just has to do with like radiation fibrosis. But I think the typical findings that I appreciate are bony exposure. Now there may or may not be a superimposed infection, so you may see some purulence and appreciate some malodorous discharge. And externally, it also sort of depends on whether they're in one of these like cyclic flares. So if they're having a flare, they may demonstrate swelling, erythema, discharge, sort of classic symptoms of an infection. Sometimes externally, as I mentioned, you can appreciate these draining fistulas. And then if there is a pathologic fracture, then just like any traumatic fracture, there may be indications such as malocclusion or a mobile segment of the mandible, things of that nature.
Yeah, it's a very wide range. Sometimes they come in and it's just a completely asymptomatic area of exposed bone and they don't even know that it's there, or somebody sent them in to have it evaluated because either their dentist or their primary ENT noticed some exposed bone. It may not bother them. And the goal is to prevent it from progressing all the way through, as Ariel mentioned, patients who have a fractured mandible and are in extreme pain and have draining wounds.
Is it typically just in one isolated spot? Can you have multiple areas of exposed bone?
Can be both. Can be any part of the mandible, basically. Usually it's one spot, just because I think usually one area of the mandible receives more radiation to it than the other side, so it tends to be unifocal. But there are definitely patients that you see where they might have bilateral or just the whole dental arch of the mandible involved.
And what's your next steps? So if you see a patient like this and you're concerned that, maybe this is ORN, what are you doing in clinic and what are you ordering as far as workup to kind of help figure out the extent of the how bad it is?
Definitely information gathering. So first understanding, what their history is. So where their primary malignancy was, what the primary treatment was, when did they first develop symptoms, what treatment, if any, have they received. Then I may do some additional diagnostic testing. So if there's any evidence of infection, purulence on exam, I'm going to culture that and send it for microbiology. Some patients have already had an initial workup or a preliminary workup and may come with imaging, but two imaging modalities that I think are especially helpful in ORN are Panorex imaging and CT imaging of the head and neck, so any type of cross-sectional CT imaging, so CT of the neck or CT maxillofacial, as long as the mandible is captured. That would be my typical initial workup, and I'd next be looking at the radiographic images to understand the full extent of their disease.
Is your CT contrasted if you're ordering it?
Typically a non-contrast CT would suffice. I would say that if there's any question, though, of, say, an infectious process where you're thinking there's maybe also an abscess that needs to be acted on, or if you're actually concerned on your exam of active cancer, then I would get a contrasted CT scan. But in a typical case, a non-contrasted CT scan would suffice.
Gotcha. Because you're just kind of wanting to see the bone, like what does the bone look like? Okay.
Correct. And then I would mention as well, though, if you are thinking that they're potentially a surgical candidate and they've had prior surgery, then you may also be getting like a CTA of the head and neck. But I think we'll also discuss a few other unique ways to find vessels for surgery if that's indicated. So a CTA is sometimes ordered as well.
And like Ariel mentioned, ruling out recurrence is important, and sometimes it's difficult because they have these vague symptoms and the exam looks weird and the tissue is irregular, the scan is irregular, and so a lot of times biopsies are indicated just to rule out any recurrence. Occasionally, you get in, and if you're doing surgery like just a debridement or something like that, you of course are sending that for pathology, sending that for culture, but occasionally you can. I have been surprised a couple times when a patient is billed as ORN, but then they end up having, unfortunately, a cancer recurrence.
Yeah, for sure. So biopsying, culturing, imaging, any role for do you get any sort of labs that are helpful?
Not usually. I mean, occasionally, we don't usually involve infectious disease. I mean, sometimes they want things like CRPs and ESRs and things like that. But most of it is just the radiographic evaluation of just how good the remaining mandible is, and that guides treatment.
Is now a good point in the conversation to talk about how you stage and stratify these patients so that we can kind of break it out into how we treat them? Okay. So maybe let's talk about the historical staging versus more contemporary staging.
Yeah, so there's some, existing grading systems. There's actually numerous because we don't really have consensus guidelines. There are a few that are more common than others. And then after this, we can kind of discuss some of the proposed modern staging systems. Historically, the Marks classification was widely utilized. It was based on the patient response to hyperbaric oxygen therapy, and this was widely adopted. However, there's been mounting evidence and growing doubts about hyperbaric oxygen's efficacy, which I believe we'll probably discuss a little bit later. And so the Marks classification system, which is based on hyperbaric oxygen, has sort of fallen out of favor. In the early 2000s, a few other classification systems became more widely utilized. Of these, the Notani system was the one that was preferred, and that's because it's based on an anatomic structure. It's based on the inferior alveolar nerve canal, or the IAN, and because it was widely identifiable in radiographic imaging and in surgery, it was especially useful for surgical planning. So the Notani staging system, based on the IAN, was kind of widely adopted, and it has stage 1, stage 2, stage 3,
based on like the involvement of the nerve or if it's progressing past it.
That's right.
Okay. And so as far as using that classification system to kind of help decide what treatment for patients, you essentially have like a 1, 2, 3 being like mild, moderate, severe. Right?
Yeah, and a lot of treatment paradigms in medicine are, largely guided by disease stage, and so that's exactly how it was traditionally used.
Okay.
Yeah, I mean, ideally, the staging system guides your treatment and is able to prognosticate kind of who's going to do well and who's not going to do well, and therefore who needs more aggressive therapy. So, as Ariel mentioned, the older staging systems weren't necessarily able to do that. Since HBO has perhaps minimal efficacy, then that staging system becomes of minimal use. And then Notani, as we mentioned, there's 3 stages. The first one is just confined to the alveolar bone, so like in the kind of dentoalveolar unit, not really deep in the mandible. Stage 2 would be not below the level of the nerve canal, so down to the level of the nerve. And then stage 3 is down through the level of the nerve canal, but that includes people who fractured, people who have fistula. Like stage 3 in the Notani system is a very broad range of patients, and so therefore it may not really be the best method for staging these patients because of that limitation.
And so in your practice, can you break down how you classify them for treatment options?
Yeah, I mean, Ariel, would you like to talk about that? Because it's really mainly the Cleveland method, which is what we use.
Yeah. So, a little bit more historically on, these treatment paradigms kind of being guided by the disease stage. So, with this Notani system, stage 1, 2, and 3, for a long time, it did sort of capture what therapeutic options we had. So for early and moderate ORN, we were mainly treating with conservative therapy. Conservative therapy ranged from close observation, maybe very selective debridement, targeted medical therapy with pento or pentaclo protocols, which I believe we'll talk about, hyperbaric oxygen. And then all the way kind of on the other end of the spectrum, you sort of had your Notani 3 or your advanced stage, but it was sort of a widely inclusive stage. And for that, the surgical option was a segmental resection, so removing a segment of mandible and what we call an osteocutaneous reconstruction. So a reconstruction with a microvascular free flap that contains bone and skin to remake the mandibular continuity. The Cleveland system sort of saw a problem in this model, the problem being that there was more granularity prior to being offered a segmental resection. So the question really became, what happens if you fail initial conservative therapy, but you still retain some mandibular integrity such that you don't need potentially that segment of mandible removed and reconstructed? And so what I'm really trying to judge clinically is what is the structural integrity of the mandible. And so Cleveland Clinic developed, a novel surgical technique called the mandibular rescue flap. And it was really aimed at patients who had moderate ORN or sort of early advanced ORN, but this sort of subset of patients who maintain some structural integrity to their mandible, where you could potentially rescue that native mandible with this novel surgical technique. And you reserved the segmental resection with the osteocutaneous reconstruction for those with true full thickness disease.
Right. So you had kind of like an intermediate treatment option for patients as opposed to super conservative and super aggressive, right?
That's right. And with the development of this surgical technique, it really beckoned a new classification system, which is the one proposed by Cleveland Clinic, which, as I mentioned, just has a little more granularity to capture those folks kind of in the middle who maybe have more advanced disease than your initial early and moderate stage folks, but aren't quite all the way advanced, what we would call like a pathologic fracture, full thickness disease. So it builds on the Notani system, which has 3 stages, and it becomes a 5-stage model.
Mm-hmm. And it's stage 3 of Notani that has been kind of broken into 3, 4, 5 in your model, in Cleveland's model.
Yeah, it gets a lot more granularity. I might be able to show a slide. So this is the new proposed staging system out of Cleveland Clinic. So again, it's adopted from Notani, which stratified ORN based on clinical and radiographic features. It expands on the original Notani 3-stage model to become 5 stages to provide greater detail and granularity, especially, as you mentioned, in the moderate to moderate and advanced disease categories. This better captures the clinical spectrum of ORN, which is crucial for identifying, appropriate candidates for appropriate treatments. Before we go through it, I'll mention that the final staging is deferred until after intraoperative debridement. So similar to cancer, where we may have a clinico-radiographic staging of a cancer, but ultimately the resection has to be performed and the pathology reviewed to determine a pathologic staging. The sort of same framework applies here. So we judge a stage initially pre-op, but the ultimate stage is determined intra-op. And so without further ado, you can see here on this mandible model, as well as the table, the 5 stages. So stage 1 is confined to the DAU, which is the dental alveolar unit, and an area of exposed bone less than 2.5 centimeters. Stage 2 extends beyond the dental alveolar unit, but it's above the inferior alveolar nerve canal, or it's confined to the dental alveolar unit, but it's a little bit larger than stage 1, so larger than 2.5. Stage 3 and stage 4 are similar in that they both extend beyond the inferior alveolar nerve canal, but stage 3 notably spares greater than 1 centimeter of vertical height on the lingual and buccal cortex, whereas stage 4, there's less than or equal to 1 centimeter of height on the lingual and or buccal cortex. And then stage 5 is your full thickness disease, so presence of a pathologic fracture.
And I guess I would add, just echoing again that the goal is to stratify patients into treatment groups. So stage 5, if somebody really obviously has mandibular discontinuity, then they clearly need a mandibular reconstruction. So like just determining in the current paradigm that we're presenting here, determining who needs a fibula free flap reconstruction is pretty obvious. In the past, it was not as much. The goal, the purpose of this is to figure out, as Ariel was saying, who has sufficient residual mandibular strength and cortex to perhaps be able to preserve their mandible and arrest or hopefully reverse the ORN process, and so therefore not have to just cut out an entire segment of the mandible and reconstruct it with a fibula, which is not ideal. In some patients, it's necessary, and in some patients are better off with that. But if you don't need to have your fibula cut out of your leg and part of your mandible resected, then that's the ideal. And then also the 2.5 centimeter in the stage 1 group, going from stage 1 to stage 2, the purpose of that, and we should probably talk about Pento, I feel like, before diving into the rescue flaps and everything, and just go down the treatment in terms of aggressiveness. But there was a paper that showed essentially that pentoxifylline and tocopherol was better, was more effective or had a pretty good efficacy in patients who had less than 2.5 centimeters of exposed bone, and it was limited to dentoalveolar units. So therefore, that's why we have stage 1, in that those patients will probably do well, or may, they have a good enough chance of doing well with medical therapy that's why that stratification occurs.
Yes, let's do that. Let's talk about how the different stages get stratified into treatment. And so you just mentioned stage 1 is going to be given the option for conservative therapy, which you mentioned, Pento, and that's for 3 months. Can we talk more about that piece of it, about conservative therapy with medications?
Yeah, so as we mentioned earlier, the use of HBO has kind of fallen out of favor. There's really never been any evidence that shows that HBO is able to really arrest or certainly reverse ORN. And it's been used for decades probably. I mean, it's really the thing that most people think of. And when I was in residency, this was a mainstay. And most people that come to the office to get evaluated for their ORN have gone through hyperbaric oxygen. It's very rare that somebody comes in, they have not already been given like 30, 40, 60 dives of HBO therapy. But unfortunately, the evidence just hasn't borne out that it is beneficial. And it was more of a theoretical benefit because the original mechanism, the mechanism is not completely well understood for ORN in general. And the original one was more of a hypoxic environment and hypovascular. And so the theory being if you can drive oxygen delivery into the tissue, then you're going to allow the tissue to be able to regenerate. But that just didn't really bear out with HBO therapies. So then came along from France this more theory of radiation-induced fibrosis and treatment targeted towards reversing that, and that was pentoxifylline, which is a medication that's used in like claudication and lower extremity vascular disease and has several effects, including decreasing viscosity of blood, like increasing the elasticity of red blood cells and decreasing platelet aggregation. But that in combination with vitamin E or tocopherol, which is kind of like an antioxidant, inhibiting some growth factors that induce inflammation and fibrosis as well. So the goal is to inhibit the fibrotic effect of the radiation and allow better blood flow through that decreased viscosity and those other effects on the cellular level to the blood itself and to regenerate bone in that method. So this was maybe 10, 15 years ago that they started doing this, and a few studies came out and showed some good effects, but they're all pretty heterogeneous and there weren't great. The data wasn't great in terms of how they were tracking these, with not all studies having good radiographic staging systems, number one, but also just having radiographic data at all. And so it's a little unclear as to how much benefit you can get from pento or pentaclo, the clo being the addition of a medication clodronate, which is a bisphosphonate, which is aimed at altering bone remodeling, but bisphosphonates have their own risk of osteonecrosis that comes along with them. So in the US, we generally do not use that. We just use the pentoxifylline, the vitamin E. And to make a long story short, it does show benefit in reversing ORN or at least stabilizing it in mild cases. And so it seems like that is around 2.5 centimeters of bone exposure, the stage 1 in this staging system.
Got it. So big take-home point is it's not worth it to send patients for hyperbaric oxygen anymore. Like we shouldn't, that's not been shown to be beneficial, and we have other treatments, right? So
it's a controversial, I think, standpoint, but yeah, there really isn't good evidence for it. So like it literally is, and we'll talk more about the cost effectiveness of that as well in comparison to like surgical techniques later. But yeah, I would agree with that statement.
Yeah. Well, and it's a hassle for patients. You have to do it a lot, right? You have to do multiple dives. It's expensive. It's not always covered by insurances. And so
it's for folks who aren't aware, it typically requires at least 30 sequential sessions, if not more. And we do sometimes see patients who've undergone 30, 40, 60 dives. And so it's a large time demand for a therapy that has not proven its efficacy. And it also comes with complications. It has a extremely dreaded complication of retinal detachment. As you mentioned, limited access, high cost financially, as we've discussed too, substantial patient time commitment.
Yeah. And with what's the dosing for the pento regimen? It's oral medications, right?
Yeah, pentoxifylline is, I believe, 800 milligrams daily. That's usually divided into 2 doses. I think the tablets come in 400 milligram, and then the tocopherol is 1,000 units per day. Then there's a challenge too, because some patients are either can't swallow pills or are feeding tube dependent. So the pentoxifylline actually is like an extended release capsule. If you take liquid, which they do have on formulary, there's problems with nausea. So patients who aren't able to take the extended release tablets can struggle with being able to tolerate the medication, although you can just break it up into, can break up the 800 milligrams into like 200 milligrams 4 times a day if they're taking liquid, or more than that to try and get the 800 milligrams in dispersed over the course of the day such that they don't have intractable nausea from the medication.
Yeah, that's a good point. Yeah, these patients are classically are very prone to have swallowing issues.
Yeah. Right? And then there's also like the traditional, kind of the original pento-clo regimen that was described in these papers initially involved various other antibiotic regimens to kind of have different phases in the treatment paradigm, but that's not universally adopted, and it kind of depends on if the patient looks like they're actively infected, whether or not you're using antibiotics, or PPIs as well were involved with that. So, I mean, generally, we're not using it as complicated as that. Generally just putting them on the pentoxifylline and the vitamin E if they're not actively infected, waiting for 3 months, see if there's a response, and then go on from there.
And if they do have an infection, like, and you get your culture in clinic and you have susceptibilities, like, do those patients usually have to be on antibiotics for like a longer time than, is it long courses of antibiotics?
A lot of people have recurrent infections, so you're kind of like, I mean, if they respond and they do okay. But the ones who don't, I feel like they just keep bouncing back and having repeated infections. And then they're kind of just like on suppressive therapy until you can get them to surgery a lot of the time. But there's a wide variation. Ariel, I don't know if you feel differently on that.
No, I agree. I mean, some folks resolve with, a 10 to 14 day course, which I might start with, but it's not uncommon to need to extend to a 4-week duration, 6-week duration. Obviously, with proper counseling, always encouraging patients to, take a daily probiotic and things of that nature, and be in communication if anything's not being well tolerated.
And do stage 1 patients usually need any sort of like debridement, or like, do you like anything procedural or surgical for that class, or usually just try the Pinto regimen?
I think if there are infectious symptoms, we'll treat the infectious symptoms. They'll all get a 3-month course of Pinto. And then if patients are still sort of symptomatic on that, or on exam, if they have, clearly necrotic exposed bone, then debridement can be offered.
Yeah, a lot of times they just have this like potentially a minimal kind of rind of bone that's clearly yellow and unhealthy, and sometimes that just falls off spontaneously and then the wound heals over. But sometimes you do just have to debride that as well down to healthier tissue. And a lot of times we do have our oral surgery colleagues assist with that, and usually do involve them, and they are oftentimes doing those more limited debridements in those cases, or head and neck colleagues. I think the mild cases are often distributed pretty widely kind of across the specialties, I think.
And so with those patients, you're going to follow them up every 3 months and then just kind of reassess, and they might get upstaged, or they might, be just improving, but slowly improving. So you kind of stay the course. And then at some point, they're either going to heal or they're going to move on. Is that kind of how you think about it?
Yeah, if they're improving, then, I mean, especially stage 1, if they're improving, then they're going to be nearly healed, at that point. If they're getting worse, then we're moving on to other discussions, whether or not they want to go ahead and proceed with the rescue flap, because it's refractory at that point to the medication.
And so with stage 2, so that would be kind of like moving them to stage 2, sort of, or they're just a refractory stage 1, or it doesn't matter?
If they're progressing, then they're going to move on through the stages if you don't intervene. Yeah.
I think if you re-imaged someone who's failing to improve kind of with the stage 1 Pinto and conservative debridement, if you re-imaged it, this is a progressive disease if you do not arrest it. And so if they're not part of sort of that patient population that arrests with that therapy, if you re-image them in time, I think you'd find that they'd meet criteria for stage 2 radiographically.
Got it. And if they're going to do well with conservative therapy, then in 3 months we would expect they should be looking better or healed.
Yeah, some sign of clinical improvement, certainly not worsening.
And so let's talk about stage 2 then. To recap, it's a bigger, there's a larger area involved, but we are still above the nerve, right? But we've got more than 2.5 centimeters of exposed bone. And so those patients, let's say they're presenting at that stage, how does that conversation go?
As Eli mentioned before, the previous study that demonstrated the efficacy of Pinto in size criteria less than 2.5. Since this is a size criteria greater than 2.5 centimeters, Pinto seems to be less effective in this group. And so the two sort of options here are, debridement or the ALT fasciolata free flap.
Can you offer them conservative therapy?
Yeah, debridement would be with conservative therapy. So you debride and you put them on Pinto.
I gotcha. So debride it, Okay.
It's a gray area here. So it's a little bit
Right.
patient driven. Do you want to try just petering along with minimal therapy and hope that it doesn't get worse? And if it gets worse, hope that it usually it doesn't rapidly get worse. It's generally a slow moving disease process. But, the whole goal is to spare as much of the unaffected mandible as possible. So you're just trying to avoid getting to the point where they might end up having fracture, might end up having just pain from the inferior alveolar nerve involvement. But yeah, it's patient driven a little bit with the stage 2.
Right. There's lots of nuance, patient factors and how patients feel about, surgery or how surgically fit they are, all these things. And so, okay, so you bring up the rescue flap. So, and you mentioned that a little bit earlier, but let's get into that piece of it a little bit more, kind of defining what that is. And because this is kind of like the newer option for these patients that are more in the moderate range, right? Something that we didn't do when I was in residency.
Correct.
Yeah, so I can kind of give folks the 50-foot view of a rescue flap. So when we say rescue flap, we're talking about an ALT, anterolateral thigh fascia lata free flap. Again, big picture is it's designed for partial thickness mandibular ORN. And sort of the philosophical goal is to preserve the native mandible and avoid a more radical surgery. The more kind of technical goal is to restore nutrient blood flow to this at-risk mandibular bone by giving it essentially a vascular highway, not just for wound healing, but for appropriate antimicrobial delivery as well.
And so it's ALT, but you're not bringing in skin.
Correct. Yeah.
What is?
I feel like a lot of people, like older people who went through training historically probably view the ALT as quite a bulky flap potentially, but as techniques have progressed in terms of perforator dissection, it certainly doesn't need to be bulky at all. And then if you're just in this case, what we're talking about is just using the fascia lata. So there's no skin component at all. There's a minimal fatty component that's like a very thin layer over the fascia, but it's an extremely thin, I think most people have seen fascia lata grafts for different purposes, or like temporalis fascia grafts. And so essentially it is that, just larger, and it has a blood supply because it's a free flap. So there's a small perforating blood vessel that's attached to the piece of fascia that we harvest, connected to a pedicle that we then revascularize to the neck, so that it has, as Ariel mentioned, a highway of nutrients and blood flow that are delivered to the bone itself.
Cool. And just kind of, do you can we talk more about just the like surgical technique of the flap, and maybe kind of like how it's different from a traditional ALT like you're doing to reconstruct like an ablation defect?
Yeah, sure. I think that, there are some similarities and differences. I think some of the similarities to, our oncologic cases are that there's a two-surgeon approach to this. So there's a surgeon doing the debridement and the vessel isolation at the head, and you have a reconstructive surgeon at the thigh. And so that's very much a similar paradigm. At the head, the person that we call the ablative surgeon are doing, a very limited intraoral approach to mandibular debridement. The whole goal is to sort of balance removing non-viable tissue without compromising the vascularity of viable bone beyond this affected zone. The other aspect for the sort of ablative surgeon is to identify vessels for a microvascular anastomosis. And so we typically utilize minimal access approaches, meaning we're making small 3-centimeter incisions over a set of vessels to identify them and prepare them for micro. We have several options for this. A lot of the times radiation may affect the skin over sort of the ipsilateral facial notch, which we might otherwise use for access to the facial artery and vein. So sometimes we favor selecting vessels outside of the radiation field. So that means you can go to the contralateral facials. You can also go to the superficial temporal artery, the STA, or even the angular artery. And then you're simply creating, a tunnel, a little vascular tunnel between your defect and your vessels. And I think if we want to bring up some images now for sort of what a debridement might look like clinically, we can kind of show you that, as well as some vessels.
Yeah, I'll bring up one of our cases. This is, you can see intraoperative debridement, so intraoral incisions, and you can see the area that was debrided here in the mandibular angle.
And you just kind of run during
a drill usually, or run during, yeah.
Okay. Until it's bleeding nicely, until it visually just looks like
correct. Till you get rid of what is obviously, it's pretty clear. I think when you're looking at the dead bone, I mean, oftentimes the texture is just soft. It does not feel like normal bone, so it's not that. It's pretty clear. And
then do you, at the extent of it, do you send some bone for micro or path or something to kind of give you confirmation that you're at the extent? You know what I mean?
It's not so much like a margin like you would send frozens for cancer, but we send microbiology and then usually send pathology at some point. Maybe if they had a previous limited debridement, not with the rescue flap, they might have had a biopsy at that point. So if there's any concern, then definitely pathology. But you're not, again, checking margins, and they can't really do frozen on bone. So it's not like you can send it to pathology and say, did I adequately get all of the ORN? It's really just a visual kind of thing. And then you're determining their new stage at that point. So, if you drill everything away and then the mandible is no longer in continuity, then now you've got a stage 5 all of a sudden. But that doesn't generally happen.
So with that picture that you were just showing, the one here on the left is kind of prepping everything, and then on the right we've got the flap inset. Yes.
Yeah. So in this case, and we'll probably talk a little bit more in detail later, but if they have a decent amount of mandibular height that is lost, then you can put some bone graft in there. I mean, usually you think of bone graft as kind of a big no-no when you're talking about irradiated wounds and mandible reconstruction in head and neck cancer. But considering the fact that we're revitalizing the area with non-irradiated fascia lata and bringing blood flow into the area, you can potentially do bone grafting, usually using morselized bone or cancellous bone, either autologous or from a donor. And then this is just some tissue and some morselized bone here, filling the defect, because it was it was down to less than a centimeter of mandibular height. And then you can see the fascia lata flap, which is pretty small, pretty thin.
This is the same patient.
Correct, same patient. And then a little skin graft. So we just put a small skin graft over the area to basically just serve as like a dressing or prevent salivary contamination. You're kind of underlaying the fascia underneath the mucosa and then laying a skin graft over the top. And this is like a couple months after surgery. So sometimes the skin graft doesn't survive and then it just granulates and mucosolizes. But in this case, the skin graft ended up being kind of the same size as it was previously. And then I'm going to move back to Ariel's here. And so I feel like you can really see how thin it is on these pictures. Yeah, this is a good view. So you're able to wrap this around the mandible.
And the pedicle is pretty long. That's why you
can be, but you don't necessarily need it to be.
Okay. Yeah.
Like in this case, they're using the angular vessels. It's pretty close by. If you don't have a previous neck dissection and they don't have fistula, and you're able to get vessels on the ipsilateral side of the neck, then it's a pretty short track to go from the mandibular area to the facial notch where the facial vessels are, or this is using angular vessels. A lot of cases, the patient has had neck dissection and then it's difficult to get ipsilateral facial vessels. So then we're either going contralaterally, as Ariel mentioned, or sometimes down to like the supraclavicular fossa, which is what we did end up doing in that other case that I was just showing you, which just pulling back. So like there's a small kind of scar down in her supraclavicular area. This was pre-op. Unfortunately, I didn't have a Panorex pre-op, but so pre-op CT, you can see kind of all this like ratty looking stuff in the mandibular angle, and it almost looks like it goes full thickness, but not quite. So that's why we ended up putting a plate and we put bone graft. But you can.
So this is a stage 4.
Yeah, it would have been
essentially.
Yeah.
And so like your second surgeon, your co-surgeon is your reconstructive surgeon, and they're harvesting a ALT fascia lata perforator flap. And so the perforator component is really important to this, not only for vessel length, but it keeps this process pretty small such that you're able to have a defect intraoral and then a small minimal access incision for your vessels connected by a small tunnel. But again, we're trying to minimize any sort of unnecessary tissue destruction. And so a really thin perforator dissection is really essential to this. And then, as you can see here, a fascia lata free flap is really independent of body habitus because we're not taking it with any of the adipocutaneous component. There is sort of a vascular arborization from your pedicle to your perforator to what I call the vascular shmoo, what I was taught is the vascular shmoo, which is sort of this really diffuse arborization, this plexus of vessels that sits on top of the fascia lata and feeds the fascia lata, which you want to preserve. And to Eli's point, this is very different than, a fascia lata graft or a temporalis fascia graft, which is naked, without any vascular shmoo, without a perforator, without a pedicle.
Yeah, because the whole point is to bring the blood supply.
Correct.
That's right.
And then going back also to a few other points about this, when people think about free flaps, again, especially if you didn't train in the last few years, potentially, or depending on where you trained, you think of this 12, 14-hour operation, patients with trachs, patients with feeding tubes, patients in the hospital for 2 weeks, and patients who aren't very happy with their lives. But this is not at all like a head and neck cancer resection and free flap reconstruction surgery. As Ariel mentioned, the small profile of the fascia lata flap, the fact that it's so thin and the fact that the vessel is so well skeletonized, as she mentioned, allows you to be able to just do this very limited dissection. So again, just as incision intraorally, that's only slightly larger than the size of the wound that was already basically there. And then more or less just a cutaneous elevation to just run your pedicle somewhere, and potentially down to a 3-centimeter incision, maybe 5 centimeters maximum if you need a little bit more exposure, or going down to lower in the neck to get vessels, and then just elevating under the skin, less than you would for a neck lift procedure. And the procedure really can take less than 5 hours to do, especially if you're working with somebody else concurrently. Patients potentially, they never need a trach when you're doing this procedure, and potentially don't need a feeding tube. Sometimes we do still use them just as a precaution, but like Mike Fritz does not ever, right? Correct. He's like never putting a feeding tube in these patients. So the recovery is vastly different. Potentially going home in a couple days, it's not at all what most people think of when they think of a head and neck free flap reconstruction. And so ultimately, this is a quality of life surgery. The patients, they have pain, they have some kind of draining wound, or are trying to avoid getting to the point where they have any of those real major problems. And so if this was not able to give them a better quality of life with a minimal hit to their existence and minimal morbidity, then nobody would go for this. But this is a well-tolerated thing, and the thigh free flap, which I think anyone would tell you that, like, of all the free flaps, it is the most well-tolerated donor site area. It's more well-tolerated than like a skin graft donor site. Patients like hardly ever complain about having this incision on their leg, and the dissection is just like not very painful. So just a very different picture than what I think most people would have in their minds who aren't used to this kind of technique or this kind of surgery.
And as far as like post-op care, you mentioned no trach, no PEG, so they're going to be started on a diet, like an oral diet, right after surgery then?
Potentially. I mean, again, we oftentimes do put a feeding tube in. It depends. For me, it depends on the extent of it. And I'm, in general, cautious in terms of like feeding patients regardless with oral cavity reconstruction. So I tend to put nasal feeding tubes and Dopphoff tubes in myself, but others are braver and feed people liquid diets immediately, or like, soft diets immediately. So the more limited it is, then the more confident I think you can feel about that.
Yeah, I think to Eli's point, it's patient specific and provider specific. But again, one of the unique highlights about this surgery is the limited dissection. And so because it's a limited intraoral dissection with a limited tunnel to vessels, which may not even be in the neck, we're taught to think, because of head and neck cancer, there being large communications between the oral cavity or the oropharynx and the neck in these large cancer operations with a high risk for a fistula. And that's extremely minimized with this kind of minimal surgery. Everything is sort of minimized, de-escalated. And so leaks are always possible, but certainly the leak rate, especially if you're going from mandible to superficial temporal, you're not even communicating to the neck.
How are you securing the flap in the defect? And does it need to be wrapped entirely around the bone, or what does that look like?
Yeah, typically that there's limited mucosal defect, and deep to that, there's a little bit more mandibular exposure. So we do a technique called imbrication, which just means that your fascia lata free flap is underlying the mucosa, completely wrapping around the mandible that's been debrided down to healthy bleeding bone. And that does a couple things. Obviously, it supplies all this vascularity that we've been talking about, but it also eliminates that dead space. And so imbrication is the process of insetting the flap deep to the mucosa and then insetting the mucosa sort of over the fascia lata, whereby you have a much larger surface area of fascia lata that's actually hugging the bone that you don't really see, and then sort of just a smaller surface area that you do see intraorally that the mucosa is inset to. And then, as Eli mentioned, typically taking a small skin graft from the thigh. Again, you're still able to close all of these defects primarily at the thigh, but the skin graft is sort of a biologic bandage. Sometimes it survives, sometimes it doesn't. But, I always tell patients we produce about a pint to a liter of saliva every day, and you're letting them PO, and there's a lot of sort of antimicrobial bacteria, rather, in the mouth. And so having a little bit of a biologic bandage on top of your fascia lata with the skin graft.
And to clarify, because I don't think we specified, the skin graft comes from, you can take your ALT free flap and then remove the skin from it, leaving your fascia lata free flap, and then you can take the skin graft from the skin that was already removed. And so they don't have a skin graft donor site because essentially it's excised from the legs, so they don't have that painful skin graft donor site that people tend to complain about and is messy, and that we're all probably pretty familiar with.
And do you have to do flap checks?
Theoretically. I mean, if you're into that.
So,
yeah, we do.
Do you have an implantable Doppler? Like are you?
Well, we don't really use
do you
that
worry
anymore
about this
general.
flap?
It's just like any flap. I mean, if it clots off, then it's going to be destroyed, and you're not going to have any of the protective effects that you're trying to achieve. So yeah, I mean, you would be flap checking this, and so yes.
How long are they in the hospital?
I feel like it depends on the extent of the defect, but anywhere down to about, 3 days minimum. I would say on average between 3 to 7 days.
Yeah, I think it depends too. I trained at Cleveland Clinic, where I think they're fortunate to get a lot of referrals for this because the procedure was invented there. And so, I think that potentially you have patients with sort of earlier stage disease getting these. And so, sometimes their length of stay may be only 2 or 3 days. And I think that, this procedure is hopefully becoming more widespread as something in our toolbox to offer, these patients with mandibular ORN. But that said, some will maybe present with a little more advanced disease and require a little more extensive surgery. And in those cases, the length of stay may appropriately be a little bit longer. But per Eli's point, again, this is really taking this free flap paradigm that we think of in oncologic surgery and really de-escalating it. The length of surgery is much shorter. The donor site is extremely well tolerated. No tracheostomy tube. In rare cases, feeding tubes, Dobhoff tubes, shortened length of stay, earlier discharge.
And if they do get a nasal feeding tube, it's for a week to 10 days. It's not a long-term thing by any means.
Yeah, just until you feel comfortable.
Yeah, just till it's healed a little bit.
Give it a little bit, give as much time as you can.
As I was doing a case with Tom Schlevy a couple of weeks ago, and he was talking to the patient's family about the feeding tube, and he was like, it's just like if you had an appendectomy, you wouldn't rub broccoli on your appendectomy immediately after surgery. So.
Seems reasonable.
Yeah. People can relate to that. So this flap, back to our treatment algorithm, we're kind of talking about this for stage, 2, 3, 4. And Eli, when we were talking about those pictures earlier, you alluded a little bit to the kind of rescue flap plus in that stage 4 class where you're adding some bone. So can we talk about that a little bit more? Just kind of how, that group might benefit from a bone graft and where that comes from.
So I think this is sort of an interesting, part about the history. So, anytime you develop a new innovative technique, there will be modifications. And so there was an early case at Cleveland Clinic where there was a patient with they were a marginal candidate for surgery. They had extensive disease in terms of mandibular involvement of their ORN, but they had a lot of severe comorbidities that precluded them from receiving a segmental mandible and an osteocutaneous free flap. So they were offered the rescue flap that was done in the manner described, but at their routine post-op imaging, I think it was a 6-month Panorex, they identified a late post-operative mandibular fracture. And so that's what led to sort of the development of the Rescue Flap Plus, and that's what's reflected in the new staging system between stages 3 and 4, whereby the mandible involvement is below the inferior alveolar nerve canal, but in stage 3, you have preservation of at least 1 centimeter of vertical height on the lingual and buccal cortex. In stage 4, it's less than or equal to 1 centimeter. And so for those folks in stage 4, they get some augmentation to their mandible integrity with a bone graft.
When you think about cancer treatment, if for those who remember that distinction between marginal mandibulectomy and segmental mandibulectomy, usually historically they used 1 centimeter as the cutoff to where you had to put a plate on the mandible if you have less than 1 centimeter mandibular height. So there's some historical precedent to the amount of mandible that you need to maintain integrity to the mandible over time, especially if you've had radiation, and most of those people who were getting resections were going to have post-op radiation. So I think it is fairly similar, but it's not, nobody knows for 100% certainty how much mandible you can remove from somebody until their mandible weakens over time and breaks, even if you're putting this fasciolata rescue flap on top of it. And so if you're able to augment it, as Ariel mentioned, to just strengthen it a little bit, then that's ideal. And short of doing a fibula, short of doing an osteocutaneous free flap, that would be doing some kind of bone graft. And again, hesitation in doing bone grafts in patients who've had radiation, but we're adding in non-irradiated tissue. That's the whole purpose of the rescue flap surgery. And if you look at OMFS literature, oral surgery literature for patients who've had trauma, there's this whole kind of movement towards these really aggressive bone grafts where they're kind of adding growth factors like bone morphogenic protein, BMP, and morselized bone graft, even just off-the-shelf cadaveric bone graft, and able to regenerate large portions of the mandible beyond like the 5 centimeter traditional cutoff that used to be used, beyond which you were supposed to get a free flap reconstruction as opposed to bone graft. And so there's, it's these cases have been done with such low frequency at this point that nobody really knows where the cutoff is and what you can get away with in terms of how much you could bone graft. But so, to make a long story short, if it's less than 1 centimeter of bone remaining after debridement, i.e. the class 4 or stage 4, then reinforcing with bone graft, whether it's patient's autologous bone graft from iliac crest or another source, or an off-the-shelf cadaveric donor bone graft, and then also potentially reinforcing with a plate that just spans the area that's being grafted, just to add mechanical reinforcement in while the bone graft is hopefully healing and incorporating into the mandible.
Okay. And so lastly then, stage 5, the treatment for that is kind of as it has been, right? Other than, I think, Eli, you had mentioned in talking before this that the big kind of, or the new approach with doing a free flap for the mandible would be potentially implants, like dental implants. Is that right?
Correct. So yeah, if a patient has pathologic fracture, then nobody's been bold enough to try and just like reduce the fracture plated, do a rescue flap and some bone graft and see whether that works. Maybe it would, I don't know. But at this moment in time, the thought is that stage 5 requires osteocutaneous flap reconstruction. Generally, that's going to be fibula. You could use scapula as well. Fibula is easier to put dental implants in. And again, like in this whole conversation, we've kind of been ignoring the dentition and the fact that patients who get a rescue flap, like that one example that we were showing where it was the whole dental arch, they have no teeth, and it's not clear whether or not you can go back and put a dental implant into a mandible that's been rescued. I don't know if Fritz has tried that. Ariel, do you know if that has been done at this point? It's scary.
It's
like nobody.
The question of the future. Agree.
Nobody wants to like go and destroy. After they've done a rescue flap, nobody wants to go and destroy the mandible by doing another dental implant. And though I'm sure, there's some percentage of patients, and maybe it's a lot. Like nobody knows like how many patients would do okay with getting implants into a previously rescued mandible. But so they don't get their teeth at this moment in time. If you get a rescue and you might lose just your lateral teeth, you might lose all your teeth, and patients do like teeth, and it's useful for quality of life. So
I'll interject with just a little snippet, but the key distinction being implant dentition.
Correct.
With rescue flaps, there is some dental rehabilitation, but not implant-based rehabilitation. And again, one of the advantages of using, again, these very, very thin fasciolata-free flaps is you are maintaining the alveolus, such that if they were to get, a denture or some other non-implant based dental rehabilitation, this is theoretically something that maintains an alveolus. It's thin, it's not bulky. You're supplying what you need to the mandible, but not creating a bulky mandible with a blunted sulcus that wouldn't accept like a denture.
Yeah. Like as you grind it down, the flatter it gets, the harder to, like if they don't have a nice ridge, like if they take down the dentoalveolar unit and then it's like sort of flat, it just becomes harder like the more you take down of the mandible, so like I'm sure of course there's a subset of patients that can definitely get denture, but if you have the whole dental arch, then that's more difficult. If they maintain some teeth, that's easier too. It's a spectrum, of course. So I didn't of course mean to assert that like you can never have teeth again if you get a rescue flap, but a benefit of if you do happen to have like a full dental arch, severe ORN, potentially with pathologic fracture, the good news is that as long as your legs have good vascularity, we can generally restore the dentition potentially immediately if like a skin paddle is not necessary to add to the oral mucosa, which usually it's not. So we've done this in a bunch of patients at this point. And I think in terms of quality of life, so we mentioned a little bit earlier that, fibula is a big hit to go through for a patient, both for the leg as well as for the head and neck site that's being reconstructed. You have much more traumatic disruption of the muscles that are attached to the mandible and higher rates of dysphagia, regardless of teeth. If you're disrupting all that musculature that's had radiation, has had a complication of radiation, it just has more edema in general, it's going to be more susceptible to dysfunction and dysphagia. And so I feel like lateral defects are more well tolerated. Initially I went through a phase, I feel like, where I did a bunch of mandibular reconstructions for ORN and all the patients were miserable. And then I kind of like talked people out of it for a couple of years. But now I feel like, especially with the teeth, because people do enjoy getting the teeth back, but the lateral defects, people do pretty well. And they do seem to go back to an oral diet relatively quickly, as long as everything heals properly in terms of like mucosal healing and no fistula formation, that kind of thing. But yeah, these are just some photos because it looks cool of when you do fibula free flap plus the dental implants simultaneously and potentially plus teeth at the same time as surgery as well. So if a patient has a large oral wound and requires skin from the fibula free flap to be put in the mouth for reconstruction, then the skin makes it challenging to place the implant posts through the skin and then attach teeth to. So generally, if we're putting skin in the mouth, we're not putting teeth in at the same time. We're putting the implants in the bone, and then like these little white caps on this picture on the lower right, those are just, it's like a Baja when they put that little cap on the Baja and then they uncover it later. So it's the same kind of thing. They go back and they uncover them and they put the teeth on down the road. But if you're able to just kind of close the mucosa to itself around the posts, then you can put the teeth on, like in this upper left-hand corner. These are temporary teeth that are getting actually attached to the fibula while it's still in the leg and then put into the patient at the time of surgery, and they're able to have teeth when they leave the table. So I'm just trying to find this one was just like a lateral one where you can see the posts that are there and then putting the teeth on there, and then they leave the OR with teeth.
Cool. So instead of having to do it later, just do it at the same time.
Yeah.
It doesn't add any sort of increased risk of complication to it.
Not as far as we know. I think I haven't seen any major problems from patients who get dental implants at the same time as the original flap transfer on patients who are not getting radiation after their surgery. It's a little less well studied on patients who are like doing it for cancer, for example, and then they're going to have post-operation therapy. And I have had a couple of like issues with some of those patients, but for patients who are getting it for ORN, I haven't seen an issue with like losing fibula segments because of putting in the dental implants.
And just speaking of kind of like complication rates, I think we skipped over that a little bit as it relates to the rescue flap, because success rates for the rescue flap are very high. You guys mentioned that in general patients do very well, but as far as rates of complication,
yeah, complications pretty low for rescue flap. I mean, I don't have a specific number. Ariel, do you know if there's a specific number for just?
No, I mean, I think the success rate is like 96% in their large series. And I think they had a single microvascular compromise. So really kind of on par with free flaps in general. I mean, that's better than actually free flaps in general. And that's specifically for the rescue flap.
And then the success rate, the 96% success rate is by far better than any other treatment that's ever been attempted for osteoradionecrosis of the mandible. So, I mean, like the stage 1 Notani or stage 1 in either classification getting Pento, I think it's about 75% of them respond. So that's like the most mild stage possible, plus like the most evidence-based medical therapy possible. 75% like maybe respond to that. So 96% from stage 2 through stage 4. I'm sure there is variation, the worse staging you have, then the less you can expect that result. But yeah, it seems like it's by far the best treatment for ORN of the mandible that's ever been developed by human beings.
There is a well-designed study out of MD Anderson looking at segmental mandibulectomy and reconstruction for mandibular ORN. And again, this is maybe at an earlier time point where, the ALT rescue flap wasn't really widespread. And so maybe there was a larger range of patients who had failed conservative therapy and therefore underwent a segmental mandibulectomy and reconstruction, who might otherwise now in retrospect have been a candidate. But, they did demonstrate high success rates of, arresting mandibular ORN because you're literally cutting it out and replacing it with vascularized tissue. But the complication rates, I think, reached up to 65%, which is extremely high. And that extended the length of stay, the cost to the hospital, and things of that nature.
Yeah, it's hard to say like what they were defining as I don't know offhand how they're defining a complication. Of course, there are little like wound healing issues and things like that, or like a donor site problem. I don't know. Like I feel like the fibula people, they do well. The worse your disease process is, then the less smooth your course is going to be, and the less happy you're probably going to be in general. So I think, again, like I used to be much more pessimistic about doing the fibulas for ORN than I am at this point. But I think that's also from the standpoint of only doing them for people that have very advanced disease, and those people are not happy and they're suffering from, pain, drainage, inability to eat because of malocclusion. So you can really improve people's quality of life by doing fibulas in those stage 5 people, but it is definitely not worth, generally speaking, going through fibula for a lesser stage ORN. And the rescue flap, I think, has really revolutionized the treatment for ORN, and for the better. I mean, because there just wasn't a great option for people that weren't in that stage 5 or that stage 1.
All right. Well, this has been a lot. Thank you both for taking the time. This is really, really great information. don't send patients for hyperbaric anymore. The rescue flap works really well, has really, really great success rates.
Can we mention, sorry to interrupt, but the cost effectiveness
okay.
also, because I thought that was really interesting when I learned that, which is that I believe like if you have a patient who's getting a full treatment of HBO versus someone who's getting a rescue flap with a 7-day hospitalization, the cost is like 50 to 25% lower than somebody who's getting HBO therapy. So,
right. And we're talking about like hundreds of like $100,000, right? Like not small amounts.
Yeah.
Right. I think I saw that in my reading that like a hyperbaric could be like 300,000 or something.
Yeah, it can be quite expensive.
So if you're talking about 50% of that, we're talking about.
Right. It's a big savings. And of time, like again, the time commitment, as we mentioned, is major. And then the most important thing is the efficacy and definitely has better efficacy. And then again, for fibula too, I don't know what the cost analysis is, but I assume for these like late stage people, it probably is still cheaper than doing HBO therapy as well. Not that I don't think anyone would really try and even do HBO for a late stage thing. And then in terms of the cost, doing the implants, which I forgot to mention earlier, doing the implants at the time of the surgery, generally that will go under your medical insurance. So the advantage of doing them at the time of surgery is that then you don't have to lump that into dental. I think they have to pay generally for like the actual teeth when they take off the temporary and put it on the permanent later on, but it becomes less costly for the patient to get them the implants in at the same time.
This is a lot of information. And I think for a lot of ENTs who've been out of training for a long time, like myself, like this will be like really like refreshing new information. So for those of us who are not doing big, head and neck cancer resection or who may not take care of these patients, like if somebody were to come into my office with, potentially an ORN of the mandible, talk to me about like referral. Is there anything I can do to tee those patients up well? Just send them straight to somebody like you guys? And how urgent, I guess?
Ideally, if you live in the vicinity of somebody that does this kind of thing, then the earlier the better, because then they're just plugged in. You don't lose time. It's a slow moving process. Theoretically, you could treat somebody who has that stage 1 disease with pento and see if they respond yourself and again get the imaging studies that we mentioned earlier on. But I think if you have access to a center that does this kind of thing, then just send them over and, we would deal with them. Cleveland invented this. We do this. There aren't that many places that do this, but plugging them in, I think, is the best thing and not wasting time with the HBO.
Yeah, I think that's a big take home for me too, is that don't waste time with hyperbaric. And for people who do free flap surgery and who may want to connect with you two just to kind of talk about more nuances of this surgery, is there a good way for them to connect with you? Do you want them to just reach out to us and we can connect you?
Yeah, or our email addresses are our first dot last names at utsouthwestern.edu. So I don't know if we can include those on the
sure. The
thing, but we're both happy to talk to anybody who's interested and wants to discuss this or anything else reconstructive related.
Awesome. Well, thank you both for taking the time. This has been a lot of fun.
Thank you.
Thanks.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening and see you next week.